Good morning. Today we will have a ward round discussion on case of acute intestinal obstruction. Dr. Anish Pandey is a third-year junior resident at RK Shapolistan, Beacon Institute of Medical Sciences, so will present, and Professor Vital Bhattacharya, who is professor and head of surgery at Calcutta National Medical College, moderate, and I'll be there. Milind, you share the scenario, and then Anish, you wait for our next discussion. Yeah, Anish, you can read this scenario.
Yes, sir. A 50-year gentleman presented with pain in the abdomen, vomiting, abdominal distension, and absolute constipation. How will you proceed to manage?
Just wait, let Dr. Bhattacharya start. So there is a patient in front of you, the ward round.
This seems to be the cardinal features of a specific condition. What is the specific condition?
Sir, the patient presented with the abdomen, vomiting, distension, and pain, and absolute constipation. So these are the cardinal feature of the acute intestinal obstruction.
Acute intestinal obstruction. What do you understand by acute intestinal obstruction?
Sir, there is a sudden onset of the abdominal pain.
Yes.
There is sudden onset of the abdominal pain which progresses to abdominal distension and vomiting, followed by the.
Yes, I understand. Yes, I understand. So whenever can you define the state acute intestinal obstruction? What is
happens? That? What happens in the intestine?
Sir, there is a non-passage of the flatus and the feces, which results in the obstruction.
So failure or progression of the contents of intestine towards the distal part. Basically, that is the situation. So can you tell me what is the broad classification of acute intestinal obstruction?
So the acute intestinal obstruction can. Sir, there is a adynamic classification, adynamic or the dynamic. Hello.
Yes. So it can be it can be a mechanical type, or it can be a non-mechanical or ileus type.
Yes.
Okay. So say if it is an ileus type, non-mechanical obstruction, what can be the possible reasons of non-mechanical ileus type of obstruction?
So non-mechanical ileus type may be due to the dyselectrolemia, sir.
Dyselectrolemia. Achha. So what is the specific type of electrolyte abnormality you were speaking about? Potassium. That means potassium increased or potassium decreased?
Sir, decreased potassium, sir.
So hypokalemic situation.
Hypokalemic situation.
Yes. Then anything else?
Sir, it may be associated with the post-operative ileus, sir, due to the dyslexia.
So operative insult to the bowel.
Gut.
So post-operative ileus. So the more the insult, the more would be the time of ileus. Okay.
Yes.
Okay.
Yes.
Then.
And
anything else?
Sir, Ogilvy syndrome,
can it be
colonic pseudo-obstruction?
Ogilvy. Yes. Pseudo-obstruction, form of pseudo-obstruction. Anything else? Where ileus can also result out of, say, huge retroperitoneal hematoma. Can there be ileus as well?
Yes, sir.
Can it be related to sepsis inside the abdomen?
Yes, sir. Sepsis of the abdomen. Yes.
Advanced peritonitis.
Advanced peritonitis, sepsis, or some inflammatory conditions as well, such as acute pancreatitis. So these are the different causes of ileus that we can see in our day-to-day experiences. Now coming on to the mechanical obstruction. So that means some sort of obstruction, not functional, but organic obstruction is within the intestines. Okay. So what can be the pathophysiological changes related to bowel obstruction?
Sir,
What happens? What are the pathophysiological changes that occur in acute bowel obstruction?
sir, there is a accumulation of the gas and the fluid inside the lumen of the gut.
So where from this gas comes?
Sir, it is due to the fermentation of the intestinal contents.
So this is one. Okay. Yes.
And also swallowed air.
Swallowed air. Yes, sir.
Swallowed air
So
is swallowed air and also the bacterial gas. Fine.
Normally what happens? The swallowed air passes aborally. Okay. Whatever we take by swallowing, that passes away through the intestine. So that cannot pass. So swallowed air accumulates within the intestine plus fermented products. Okay. And what about the collection of fluids?
Sir, there is a fluid sequestration in the intestine.
Where from this fluid comes? Where from this fluid comes?
Sir, from the excessive secretion from the bowel wall.
Excessive secretion from the bowel wall.
And defective absorption.
Defective absorption. Plus the secretions.
Normal secretions.
That are being poured within the intestinal lumen. So that is about the collection of air and collection of gallus. So this is one abnormality. Accumulation of fluid, accumulation of gas. So this is one change. What are the other changes?
What is the anatomical change in the gut?
Sir,
what happened at the point of obstruction? At the point of obstruction, the obstruction 1 point, what happens to the gut?
Sir, vascular supply.
Before that?
Sir, venous compromise.
Yes.
Compromise.
So what happens then? Venous compromise state. Acha. Okay. What happens?
Sir, first
particularly
venous
compromise. Okay. If it is particularly a closed loop type of obstruction, venous compromise. Okay. The mesentery becomes occluded. So the veins become occluded. And what is the resultant effect when the veins are occluded?
Sir, there is a venous congestion ultimately which leads to
that leads to intestinal wall. Intestinal wall edema. Intestinal wall edema. Intestinal wall becomes grossly thickened. And when the intestinal wall becomes thickened and there is a closed loop obstruction at a particular point, what happens next to that?
Sir, bowel may undergo perforation or strangulation.
The next point. So initially it was a venous obstruction. Now the intestinal
then arterial, sir. Then it progresses to the
yes.
Arterial obstruction.
With the development of edema, it becomes more compromised. The arterial circulation becomes occluded. So that can lead to gangrene or
strangulation.
So this is second effect. So the patient suffers from vomiting. So this persistent vomiting that can lead to what pathophysiological changes?
And another anatomical change is you are not mentioning that the point of obstruction proximal to that gut start distending. Distension of the gut is another pathological effect which can lead to some other consequences. What happens if the gut is distended? What happens in the gut? Normally small gut does not contain a lot of bacteria. Once there is obstruction, what happens? There is bacterial proliferation.
Translocation of
the bacteria. If the gut gets distended?
So if the gut gets distended, there is a injury and there may be the bacterial translocation into the bloodstream.
Yes. So there is gut distension, and this distension can also cause venous compression and consequent ischemia and bacterial translocation. So, Dr. Bhattacharya asked you what are the pathophysiological changes? So first talk of these basic changes in the gut, and consequent to that, once the patient starts vomiting, this patient also goes to some biochemical changes.
Yes.
And how is the biochemical changes decided? What will happen to these biochemical changes? That depends on?
Sir, site of the obstruction.
Yes.
Yes,
So
sir.
if
Sir,
the
Yes.
obstruction is high up, something
Yes, what happens?
sir, in the
more
distal
distal.
bowel of, sir, in the proximal bowel obstruction, there is a vomiting which leads to the dehydration, which causes the
No,
metabolic
no.
alkalosis.
Yeah.
Vomiting is
So,
more predominant.
Yes, sir. Vomiting is
proximal
predominant.
small.
Sir.
Yes.
Sir.
So what happens?
And
What are the net biochemical change patient
Effect.
will be having once
sir,
the
due
patient
to the
comes out of
vomit, sir, due to the vomiting, there is a dehydration which results in the hypochloremic, hyponatremic, hypokalemic metabolic alkalosis along with the
Yes, yes.
paradoxical aciduria.
and there is a more distal small bowel obstruction.
Sir,
Now,
in the
if it is more, yes.
sir, it is
What
if it is
happens?
distal bowel obstruction, then distension will be the first, and there is a fluid sequestration in the small gut, which
So-
leads to the distal bowel, which leads to the metabolic acidosis. Sir.
Why?
In other words, volume loss will be more pronounced in which situation? Proximal bowel obstruction or the distal bowel obstruction? As we go down, the volume loss, or as you go up, volume loss would be more commonly found in which situation?
So as we go down,
Yes, yes.
as
The
we
more
go
you
down,
go down, the more distal is the obstruction, volume loss becomes more evident. Okay.
Why
yes,
there is metabolic acidosis? If you have a more distal small bowel obstruction, why acidosis?
sir, there is a sequestration of fluid which leads to the hello.
So what are these contents in the small bowel?
एक टुकड़ी मेरा कॉपी था 45 का फाइल
Hello.
These contents are mostly pancreatic secretion, biliary secretion, small gut secretion. Which contain lot of the sequestration is having lot of bicarbonates.
Yes, sir.
Vomiting may not be so much a predominant. So it will be a combined abnormality depending on the amount of vomiting and amount of sequestration. Okay, fine. So you have the pathology changes and this, and now this is a patient. With these 4 symptoms are given to you, how are you going to assess this patient?
Yes, sir. So firstly, I will go for the general examination of the patient. I will
No more
look for-
question to be asked. No more
Sir,
question.
No,
I-
no, go on, Dr. Shah. I'm listening. Yes.
You don't
Sir,
ask,
first of-
to ask some more question. I am not happy. I want to come to a reason etiological diagnosis. I want to
Oh,
know whether the
yes,
patient
yes.
has
So,
got
as,
strangulation or not.
yes. So, before that, let's pass on to that. What are the possible situations where the mechanical obstructions
Yes.
can develop in a small bowel?
Common to rare, suppose.
Sir,
Common
first
to
of all, the most common cause is the adhesion.
Yes,
Hello?
adhesion.
Then, sir, it may be due to the obstructed, sir, hernia,
External hernias.
So,
external hernias, and sir,
Can it be-
malignancy.
can it be internal hernias as well?
Yes, sir.
Huh? So,
Yes, sir.
external hernias.
And internal.
But that is rare actually, internal herniation. Okay. So external hernia is more common in that sequence. Okay.
Yes.
So hernias which
Sir,
can be either external or internal. Then go on.
Yes, sir. Sir, it can be due to the malignancy. It
Before
can be
that,
due to the, sir,
malignancy is not that common. There is more commoner causes.
inflammatory bowel disease.
Huh?
Inflammatory bowel disease.
Tuberculosis and the inflammatory bowel
Tuberculosis.
disease.
Yes. And then
And then, sir,
any other benign cause? Can there be a rotation of any segment of the gut? What is that
the
called? as?
volvulus.
Yes. Volvulus.
Volvulus. And the,
And then talk
So-
of some tumors. Tumors may be benign tumors. Some benign tumor may be the cause of obstruction. Then benign tumor can lead to another condition. If there is a
intussusception,
polyp
sir.
in one segment of the gut,
Yes, sir.
in an adult patient,
Then-
this can cause what?
Intussusception.
So yes, submucosal benign tumors or intramural benign tumors can also lead to intersusception. Okay. So
The commoner causes which you come across
yes.
in your practice.
Yes.
Small bowel malignancy is not very common. In an elderly patient, you may have large bowel malignancy, which usually presents with acute and chronic obstruction. Patient has features of chronic obstruction and then go into the acute obstruction. If we talk of acute obstruction, it's mostly a small bowel obstruction.
Yes. Now, can you state some situations where there is only the lumen of the bowel is compromised, but not the wall, not any external effect?
Sir, lumen of the wall. Sir, if in case of the impacted stool
Mechanical
is there,
obstruction, impacted feces. Acha, this is what.
Feces. And
Achha,
gallstone ileus, sir.
What is that situation? Gallstone ileus?
Sir, there is a perforation of the wall of the gallbladder, which leads to the spillage of the stone.
Is it perforation? Is it perforation? Free? It's not a free perforation.
Say fistula formation.
Fistula formation, yes.
Between the gallbladder and the small bowel. It should not be a cholecystocolic fistula. Cholecystocolic fistula will not cause obstruction. Is a cholecystoduodenal or cholecysto small bowel fistula.
Yes.
And what happens then? The stone?
The stone passes into the small bowel. Which
is it usually a small stone or it's a large stone?
A large stone.
Yeah. Yes, it is likely to be a large stone.
Yes.
That can obstruct the lumen. So where is usually the stone lodged, causing obstruction?
The duodenum.
Duodenum.
Sure. Duodenum. Yes, that can also sometimes occur. What is the syndrome known as? If the pylorus or the proximal duodenum becomes obstructed by a gallstone passing into the duodenum. Have you heard the term Bouveret syndrome? Bouveret syndrome, a type of gallstone ileus?
No, sir.
Achha, okay, Bouveret syndrome. Now, can you tell me what is the classic triad of gallstone ileus?
Sir, intestinal obstruction, sir, pneumobilia, and radio quick shadow in the X-ray.
Why there is pneumobilia?
Sir, there is a due to the fistula formation, there is a gas goes into
from the bowel
biliary system
to the biliary
system.
Oh, okay.
This is described as regular strad.
Regular strad.
This is a regular strad. So done.
So now, a lot of questions to be asked. You understand? If you say these are the important causes, you need to ask a lot of questions. Adhesive obstruction will be diagnosed by what? Whether the patient has got any previous operation or not.
Operation history, yes.
Then hernias, you can ask patient some question whether he has got swelling in the groin. Yes. And swelling become recently irreducible. Okay. Yes. This is a 50-year-old gentleman. He may have a situation that there is a either inflammatory bowel disease or patient may have some neoplastic lesion. And I am not sure whether this patient has got a large bowel obstruction leading to this classic acute features. So you should ask the patient some more question to find out the possible etiology. Second is, this patient need to be differentiated between a simple obstruction and a strangulating obstruction. What additional feature you will have in the symptom the patient has got a strangulation obstruction?
Sir, the colicky pain when becomes the diffuse constant pain, maybe suggestive of constant continuous pain.
And then what else?
And sir, patient is looking toxic. Patient has fever, fever, guarding. On examination, there is guarding or rigidity.
Then examination will come later. What I'm saying is, you need to ask some more question before you pass into the. You say, I'll do a physical examination. The point is, in a ward round scenario, you are given few points, and you need to answer that. I like to take. You need to do a comprehensive assessment of the patient. Number one, clinical. Number two, some lab, some readily investigation, and then plan for management. Got my point? For ward round scenario, this is the approach.
Yes. Hello. Hello.
Yes. Yes. So, hello. Hello.
Hello. Yes, sir.
Yes. Continue. How do you assess the patient? Whether the patient has a simple mechanical obstruction or a septic obstruction. Yes, go on. So
Sir,
you have seen that the changes in the character of pain. This is one.
Yes.
Okay.
And
What
sir,
are the other changes?
Sir, history of fever may suggest that there is a strangulation. And
Sure. History of fever.
and
Can
then, sir, yes. Hello.
Yes,
can
yes.
duration be another predicting factor? Duration of presentation.
Duration of presentation, sir.
That means duration of the symptoms. So if it is more than 3 days, more than 4 days of obstruction, so you have to suppose that there is every possibility of a septic abdomen as well, following mechanical obstruction. Okay. And then this is part of history. So pain changes in the character of pain. And what about the general features? What will you see in the general survey of the patient? What happens?
The patient will be looking toxic. Patient have hypotension, tachycardia, and signs of shock. Hello.
Yes. And what about the
hemodynamically unstable patient? Yes.
Hemodynamically unstable patient, sir. And
Fine.
sir, on the abdominal examination, we may get the tenderness, and the rigidity and the guarding, rebound tenderness, sir.
And what else you should look for? You are looking at a patient who has got
Visible
distension,
bowel sound.
obstruction. Before bowel sound, there is a very important point in inspection to be made out in a patient like this, to look for any visible
peristalsis. Yes.
So suppose patient has got a visible peristalsis. What in peristalsis to be looked for? Can you make out from which part of the guard the peristalsis is coming up? By looking at the
Sir, in the small bowel obstruction, the peristalsis will be seen in the central and in the step ladder pattern.
Yes, good.
And
so it will be a step ladder pattern and peristalsis in the central abdomen. And if it is a larger obstruction?
Sir, it mainly seen in the periphery, and it depends on the point of obstruction. Sir.
Yes.
So flank distension.
Yes, sir.
So you have to see, you see, clinical part is also important. And you should look for the hernial sites. When you examine the patient, look at the hernial sites. Whether the hernia is there, whether the hernia is irreducible, and there is any features of strangulation in the hernia.
Or yes.
Okay. It is not possible to diagnose internal hernias by clinical examination.
Yes.
Okay, so this patient is having these symptoms for about 24 hours, and he is admitted in the hospital. And what are the steps of management? We have done the clinical examination, no hernias, and the diagnosis is just an obstruction, and cause cannot be ascertained on clinical examination.
Sir, firstly, I will resuscitate. Sir, I will check up. I will examine the patient. If there is a feature of hemodynamic instability, I will first resuscitate the patient, and then I will go for
how will you plan fluid therapy this patient?
First of all, I will secure the IV line and start IV fluid. Then I will do the
IV fluid. What? You said that
IV fluid.
It can be a metabolic alkalosis.
Yes,
because of
metabolic acidosis.
Acidosis in view of less vomiting, more of distension. So what fluid you should choose?
Sir, if there is a more vomiting, then I will go for the normal saline solution.
Yes.
And if
don't
there
start
is
lactate on the background,
yes,
metabolic alkalosis, don't start the patient on lactate solution. Start normal saline. Okay.
Saline.
The other way around, start on the ringer solution. Fine.
Yes. And then, sir, I will put Riles tube catheter, and then I will start empirical antibiotics, and then, sir, I will go for the X-ray abdomen, sir, radiological investigation.
What do you expect in X-ray abdomen?
Sir, I will go for the supine X-ray abdomen. I will look for the air fluid level.
Supine, only supine.
Sir, I will go for the erect and supine both, sir. But
I allow you one. What do you want?
Sir, I want supine.
Huh? Supine, yes.
I
Why?
want supine. Sir, because in
Supine
supine
will not give air fluid level. Supine gives a very good delineation of the gas schedule.
bowel. Yes, sir, gas schedule.
And how do you now find out, yes, this gas schedule is small gut or large gut?
Sir, in the small gut, there is a dilatation of the bowel, mainly seen in the center part, and there is some different features of the small bowel, like sir in the jejunum. In the jejunal, if the dilatation is of the jejunum, we see the stepladder pattern, and we see the volvule conventus in the form of the white line in the gas-filled gut. And sir, if there is a ileum, there is a central dilatation of the bowel, but volvule conventus is not there, and the ileum is generally featureless on the X-ray. And sir, in case of the large bowel, we mainly see the dilatation around the periphery.
Just one point. If it is obstruction in the small bowel, so you have said that the central disposition of the distended gut accepted, multiple air fluid levels. Yes. Anything else in the at the periphery, say at the cecum? So absence of cecal gas shadow.
What do you expect?
Absence. Yes. Hello.
Hello. Yes, sir.
Yeah.
Go on.
Large gut will be distended or collapsed?
Large gut will be, sir,
Small bowel obstruction.
Yes, small bowel obstruction collapse.
Yes.
So usually cecal gas shadow or the rectal gas shadows are usually not seen in small bowel obstruction, isn't it?
Yes. Yes, sir.
And what happens in the large bowel obstruction is usually, what about the plain X-ray? What happens?
Sir, mainly there is a dilatation of the bowel wall will seen in the periphery, and there is a presence of the hostrations, which are incomplete mucosal folds.
So dilatation of the disposition of the colon right up to the site of obstruction, Site of obstruction.
Yes.
What is the classic plain X-ray feature in a volvulus, acute sigmoid volvulus? What is the classic description? If you see the picture, you can make out this is a sigmoid volvulus.
So there is a coffee bean.
Yes.
Coffee bean sign, sir.
What is that sign? Yes, coffee bean sign. What do you understand by the coffee bean sign?
Sir, there is
what is the anatomical explanation of the coffee bean appearance?
Sir, there is a dilatation of the bowel loops, which is pointing towards the in the sigmoid volvulus is pointing towards the right hypochondrium. Right hypochondrium.
Yes. Originating from converge. They are convergent towards the left iliac fossa.
Left iliac fossa, yes, sir.
Okay.
There is hugely distended gut loop, and you can make out 3 lines in this gut loop.
Yes.
From it, yes, sir.
And one intervening, all pointing towards the pelvis.
What are the 3 lines? What are the 3 lines?
Sir, the outer 2 lines are the outer walls of the sigmoid, and the inner line is the
intervening
line. Yes.
And this is
what is that?
Compressed
mesentery.
This is
described. Sir, from it, sir, sign from it.
Dahl-Froment sign.
Yes, sir.
Yeah, fine. Okay. Small X-ray shows evidence of small bowel obstruction.
Yes, sir.
What should be your next step?
So first,
you are not sure about the cause of obstruction, and you are not sure about the strangulation also. Why strangulation is important to diagnose strangulation?
Sir, we will not wait for anything. We will just go for the surgical.
So strangulation require early surgical intervention.
If the
patient has features of strangulation, he will need early intervention. Yes. So how will you now proceed? You have just an X-ray saying that small bowels are distended up to the terminal area.
So first of all, I will differentiate whether this is a strangulated or simple obstruction. And if there is a strangulated obstruction, I will go for the urgent surgical approach.
No. The point is that yes, you have done the plain X-ray. Now you want to know certain other points as well. in a
Yes, sir.
small bowel obstruction. What should be the next imaging?
Yes,
And what
as I
are
said,
the objectives of
strangulation may not be always be diagnosed on critical ground. Understand?
Yes, sir. Yes,
If
sir.
you have classic features of rebound tenderness, patient is in shock, patient is looking toxic, yes, there is one clinical straightforward diagnosis. But sometimes it is equivocal. You cannot diagnose strangulation clinically. Then
Yes,
what?
sir. Sir, I will go for the contrast enhanced CT scan of the abdomen.
Yes.
with the object of Kiki Janti Chao? What are the things you want to know?
Sir, first of all, I want to know about the pathology, whether this is inflammatory or the
Pathology.
neoplastic.
What is the etiology? What is the etiology? What is the
Etiology.
site also? What is the
Site, yes, sir.
site?
Site of the
And
obstruction.
what is the degree of obstruction and whether there is any sepsis?
Strength.
Yes,
Yes,
so all these things
Strength.
you want to know. Okay.
Yes, sir. And sir, we also
CT can also give a very good diagnosis of
strangulation.
intestinal ischemia.
The strangulation. Yes, sir.
Ischemia, bowel. Yes. Yeah.
Yes, sir.
So in this connection, can you tell me what is whorl appearance in CT scan?
The word appearance is seen in the volvulus, sir. There is a
Yes.
mesenteric vessels. Sir.
Twisting of the mesentery, including
Mesenteric
the veins around the axis, mesenteric artery. Okay, that gives rise to the what is known as the whorl appearance.
Word appearance. Yes.
Okay. Yes. Yes. So with these objectives, we want to do is CCT. Okay.
Yes.
360. 60.
Hello.
65 lakh.
Hello.
It
Hello.
is mute.
Hello.
Hello.
Anish, now
Yes, sir.
if I give you a situation that this patient is likely to have a adhesive
68.
small bowel obstruction.
Sir, not able to hear, sir. Adynamic ball.
I give a scenario that this patient
Yes,
is likely to have a adhesive small bowel obstruction. What is
Yes,
the
sir.
strategy for managing adhesive small bowel obstruction? Adhesion may be congenital adhesions or maybe some post-op adhesions. What is the strategy for managing adhesive small bowel obstruction?
Sir, I will go for the non-operative management. I will go for the conservative management, and I will look whether the patient is improving or not. If the patient improves after the conservative management, then I will continue. And if there is no improvement in the patient's condition, then I will go for the surgical
What is the time?
approach.
What is the
Hello?
time?
Sir,
There is a
24 to 48 hours, sir.
No, for adhesive it is more. If the patient has got, you see, adhesive obstruction may also have strangulation.
Yes.
If adhesive obstruction is actually strangulation, patient should go to
Yes,
for
sir.
early surgery. If the
Yes.
patient is not having strangulation, there are some current guidelines for managing adhesive small bowel obstruction. Okay, so if the patient does not have features of strangulation, we are the patient who can wait for about 72 hours.
Okay.
If the patient is not deteriorating, try to get the
Yes.
point. Adhesive
Yes,
small
sir.
bowel obstruction are mostly managed by conservative means
Conservative management. Yes, sir.
because you operate, again patient is going to form adhesions.
Yes, sir.
Okay, so
Yes,
for
sir.
adhesive obstruction, waiting is more. For a mechanical obstruction, for other reason,
Okay, sir.
when you like to
24.
intervene?
Sir, 24 to 48 hours. If there is no adhesion and there is a mechanical obstruction.
Fine.
How will you assess that the patient is improving during this initial observation period and frequent observations?
Sir, we'll assess the patient by looking at the abdominal distension, whether it is improved, it is going down or not. Patient pain. And
how will
sir,
you assess that this abdominal distension is gradually been decreasing?
Yes. How do
sir,
you assess?
abdominal, sir, girth measurement, abdominal girth.
Yes, that is important. You should have serial girth measurement.
Yes.
That is a clinical assessment.
Yes, sir.
And improvement in pain.
Yes, sir,
Patient may
improvement
start
in
passing
pain.
flatus.
Yes, sir. And sir, in the Riles tube aspirate, if you see there is a decrease in the Riles tube aspirate, sir.
Suppose you have done a CT scan and patient
Yes.
is not showing any features of strangulation. Is there a role of taking an X-ray of the abdomen after 24 hours?
Yes, sir.
How do you interpret that?
Sir, if the contrast passes into the colon after 24 hours, the patient is having pseudo obstruction, not the mechanical obstruction.
Patient may have a situation that obstruction is getting relieved.
Relief. Yes.
In this obstruction, the patient may have some relief of obstruction.
Yes, sir.
Okay. Or if you find the whole contrast in the small and large gut which is distended, yes, that is a situation of ileus, paralytic ileus. So we can discuss the little operative part.
Yes.
Yeah.
Just one point. Now, one clinical situation. Now, if it is basically an intersusception, what would be the typical clinical findings related to intersusception? Adult intersusception.
Sir, clinical findings means in the radiological, sir, or in the examination?
So
Clinical.
that comes next. That comes next.
Patient has got a intersusception, and there may be some additional features with the presentation. Suppose it's very late presentation.
Strangulation, sir.
Strangulation, and what is going to happen if there is a strangulation of intersusception? This patient may have some more features, like in children it is described as a classic sentence.
Empty sign, sir.
What
dancing?
Is
Dance.
No. If there is a strangulation in a intersusception, patient will have GI bleed.
And that will be manifested. That will be manifested in the form of what is classically known as
red currant jelly, sir.
Yes, that is more only
red
found
currant
in
jelly.
children. Or in adult patient may have altered blood.
Yes.
Okay.
And what happens to the right iliac fossa?
Sir, empty right iliac fossa, empty.
Yes.
Empty right iliac fossa side. And what
if it is too late?
Any lump will be palpable per abdomen. Sir has said if it is somewhat late in its presentation. Any lump?
Yes, sir, lump will be palpable. Yes, sir.
Where? And what is the type of the lump? It's basically a sausage-shaped lump.
There is a classic description. It may be sometimes difficult to feel, but there is a classic description.
Yes.
A lump may fail, and if it is too late, the intersusceptum can come out of the anal orifice.
Oh.
As well, can come out of anal orifice in a very late advanced case.
So that will look that may even look like a prolapse.
Yeah.
Go on, sir. Dr. Shah, go on.
Yeah.
The surgical treatment.
You have decided that if this patient will need surgical intervention.
Yes.
What surgery you plan for this patient? Is there any role for putting a laparoscope in a patient with acute intestinal obstruction? Any we are in PG, not MBBS, so I am asking you this question. Any role for putting a laparoscope in patient having acute bowel obstruction?
Sir, for adhesive bowel obstruction, we can go for the laparoscopic. Laparoscopic, sir.
Automatically stable, because you are going to create a pneumoperitoneum. Hematologic transcription, you can't do that. So if the patient is otherwise humanly stable, surgeon is experienced, you can put laparoscope, because it is said that if the patient has got adhesive obstruction, managing this by laparoscopic means will be better, because this will incite less adhesion subsequently.
Yes.
And some intraabdominal condition may be managed by laparoscopy. But surgeon should be experienced, because gut is distended. There is every possibility that it can injure the gut while doing this diagnostic laparoscopy. There is a role. Okay, it's not that laparoscopy is contraindicated in acute bowel obstruction. Now you have gone by midline incision.
Yes, sir.
Now, one point regarding the laparoscopic surgery. If you proceed for the laparoscopic surgery, it is said to be less adhesions will subsequently come out. Okay, so why it is said so? Laparoscopic surgery invites less adhesions postoperatively in comparison to the open operation. What can be the possible explanation?
Sir, less bowel handling, sir.
Yes.
What else?
The more,
Handling and
the
also
more,
does incision
yes.
length matters? Does length of incision matters?
Yes.
Yes. You cut the whole layers of the abdominal wall, make a long incision. There is long suture line, so there is more inflammatory response.
Yes.
The less yes, the micro injury to the peritoneum, be it visceral, be it peritoneum. If it is less, there will be less fibroblastic response or adhesive response.
Yes.
The less you injure, even if it is a microperitoneal injury. Yes, go on. Dr. Shah, go on.
Yeah. You have made a midline incision and you have suspected patient has got a acute small bowel obstruction. What are the steps for laparotomy in a patient like this? How do you go in and diagnose, manage?
So firstly, after
I'm
opening
sure
the
you
abdomen,
inside midline. I am sure inside midline.
yes.
Where you start? Xiphoid to symphysis pubis. Where do you make the incision first? Classic description
So
is?
from xiphoid to the
No.
from
It should be,
xiphoid to the
no. It should be midline incision. Because you don't know the site of obstruction. It's a midline incision. Half above umbilicus, half below umbilicus. Got it?
Yes.
So you made a midline incision. Go into the peritoneal cavity. Tell me the steps for managing such a patient with intestinal obstruction. What do you do first on entering the abdomen?
Sir, after entering the abdomen, I will first look for the first search for the cecum, and
Yes.
I will see whether
And
the
before
cecum
go
is
to the
collapsed.
cecum, on opening abdomen, there may be hemorrhagic fluid
Peritoneal.
coming out,
Yes.
which happens in case of strangulation. So if there is
Yes.
hemorrhagic fluid, you drain this toxic fluid.
Yes.
And then go to the right leg fossa.
Yes.
Cecum is collapsed or cecum is distended. What is the classic situation of acute small bowel obstruction? You find cecum is
Sir, collapsed.
collapsed. What next you do?
Sir, then if cecum is collapsed, then sir, I will see the site of the obstruction by. Hello.
Where from do you start? You have seen the
Sir, from
cecum. You have
You
seen the
start
cecum.
with the
Yes, cecum.
cecum is collapsed. And
Then,
now you are
Hello.
saying small bowel obstruction.
Hello.
Which part
Yeah.
of the gut is easier to handle? The collapsed part or the
Sir,
distended part?
distended. Sir, distended part is
Distended
easier
part?
to handle.
No. If you start handling the distended part, you may cause serosal tear. Your target is what? Target is to reach
Release
the
of the
junction of
obstruction.
collapse in the distended part.
Distended part. Yes, sir.
So you bring out a collapsed segment of the gut. Don't bring out the whole distended segment. It will be difficult to reach the junction. You bring out a collapsed segment of the gut and try to reach the junction of collapse and distended segment.
Yes.
Okay.
Yes.
And you can find the site of obstruction. And your surgery will depend on the cause of obstruction.
Cause of
etiology.
obstruction. Yes.
Okay. If it is just a simple band, there will be a single band causing obstruction. So lysis of the band will be the answer.
Yes.
Now you have a very distended small bowel and you cannot close the abdomen because of the distension. How do you decompress?
Sir, retrograde decompression I will do.
How to do that?
Sir, I will milk the distended bowel towards the small bowel, then towards the stomach, and I will aspirate through the nasal.
So the best
Can
way
we-
to decompression is retrograde decompression. Don't do enterotomy and take this secretion out from the enterotomy. It is best to decompress by retrograde decompression and ask the anesthetist to keep on sucking the
aspirate.
nasogastric tube.
Gastric aspirate.
Can it lead to an increased incidence of postoperative aspiration?
Yes, sir. But sir,
Can it be can it be propelled towards the large bowel as well when the obstruction is released?
Sir, not understanding the question, sir.
I mean,
anti-gate decompression.
Anti-gate, yes, sir. Ileus.
It's sometimes difficult to do it.
The obstruction.
Yeah.
Okay, proceed, Dr. Shah. Yes.
Yeah. You will find a segment of gut which is showing borderline viability.
Yes, sir.
You cannot decide to resect or not to resect. What
What
will
will
you do in this situation? You find a segment of gut which is looking doubtfully viable. A
yes,
black flaccid gut has to be resected.
Yes,
That
sir.
is,
You see, yes, you could find that it was a closed loop obstruction. You have released the obstruction, and the
Yes, sir.
intervening bowel you have to inspect now. Whether that is a living gut, whether that is a dead gut, or whether that is likely to leave that segment of the gut. How will you ascertain?
Sir, the leaving gut will be the pink. There will be peristalsis on stimulation. There is a mesenteric pulsation can be seen. But sir, in the case of the dead, there is the bowel will be lusterless, pale.
What is the appearance of the gut? What will be the clinical appearance of the gut? Inspection.
Sir, in the living, it will be look pink, sir.
Yeah. Look
Pink, sir. Pink.
pink. Achha. Yes. And it will on while handling the gut, it will look like firm and elastic. Normal gut feels firm and elastic.
Yes.
Normal gut. Yes. So pinkish in appearance, firm and elastic. Seeing the peristalsis and feeling the pulsations. Okay.
Yes.
So two extremes are fine. Two
Yes,
extremes are fine. Normal gut and the gangrenous gut. What I'm saying is there is a doubtful viability. What you do to assess this segment of gut resect or not resect?
Sir, first of all, I will ask anesthetic to supply 100% oxygen.
Yes.
And then I will keep a hot mop over the suspected bowel and wait for the 10 minutes. And then after 10 minutes, we assess the normal appearance of the bowel. If it is pink and if peristalsis return and if there is pulsation can be seen.
The color might change, pulsation may come back. Now, is there a newer gadget now available in our armamentarium to say, yes, I can assess it by something else in the operation theater itself?
Sir, Doppler, sir, or dye, sir, dye.
Doppler is one, yes. Doppler is
dye,
one.
sir.
And what dye?
Dye, sir.
What dye?
IGC, sir. IGC?
IGC nahi hai, ICG.
In ICG, yes. Indocyanine green.
So you can use indocyanine, and if a imaging system, you can see that the gut will fluoresce.
Yes.
So if you see the gut is having fluorescence with ICG, you can say yes. Now ICG is now being applied in a lot of situations, even in a routine resection, where before doing anastomosis, you assess the margin of the gut by doing ICG fluorescence. Okay, so doubtful viable gut may not be resected straight away. You can wait for some time with some measures and then see whether this returns or not.
Yes.
Okay.
Yes.
You find there is a single stricture in the terminal ileum, possibly because of tuberculosis, and the stricture is the cause of obstruction. How will you manage this stricture? How will you manage stricture? Stricture is the cause of obstruction.
Sir, I will do the stricturoplasty, sir, longitudinal incision over the bowel, and I will transverse close the bowel.
Yeah, if it is a single stricture, a operation described as stricturoplasty is acceptable.
Yes.
If you have multiple
so one question is whether you will proceed for stricturoplasty or resection. What will be your guidelines?
Sir, stricturoplasty, sir. If there is a single stricture.
No, the question is stricturoplasty versus resection. What would be the operative guidelines? Yes, I will resect this stricture and I will resect. I will go for a stricturoplasty. Do you understand? Stricturoplasty versus resection. What are the indications for going stricturoplasty? What are the indications for going resection of the gut, segment of the gut?
You see, there are different types of stricture. If you have a long segment stricture, stricturoplasty may not be feasible.
Yes.
Understand?
Yes.
If it is short segment stricture,
Multiple strictures.
you have multiple stricture in closed segment of the gut. The idea is conserve. The idea of stricturoplasty is conserve gut. So if you have a stricture which is having a long segment, then how far you will make the incision to make the stricturoplasty? So short segment stricture, a fibrotic stricture is amenable for stricturoplasty. A long segment stricture may not be a suitable candidate for stricturoplasty. Multiple stricture in close succession. You see, if you have 2-3 strictures, a long distance, you can do multiple stricture.
Dissection.
Okay?
Yes.
Done. Go on, Dr. Shah. Proceed.
So you have found a patient. This patient is having a diagnosis of sigmoid volvulus, acute sigmoid volvulus. What is the strategy for management patient being acute sigmoid volvulus?
Sir, if there is a no sign of strangulation or perforation, then I will go for the endoscopic or sigmoidoscopic derotation.
Yes.
And
So
if
most important is before you go for this decompression, you should be clinically certain that the patient does not have features of strangulation. This is contraindicated in the patient's strangulation. So try for a sigmoid. This becomes successful. Sometimes you can gently try to pass a flatus tube, not under force. Sometimes you can try, but ideally now with the advent of these endoscopic facilities, we should suppose endoscopic decom has been successful. That distension has gone down, patient is relieved, and a lot of fluorescence has come up. What is the next management? You discharge the patient next morning?
No, sir, I will go for the sigmoidectomy, elective.
Why? Why?
Sir,
Why
there
you
is a higher chance, sir, because of chance of the recurrence, sir. The patient may
chance high as high as more than 50%.
80 to 90. Yes.
More than 50% chance of recurrent volvulus in a patient who has got a volvulus once. So in that case, you should prepare the patient. In this situation, the emergency is over, and you prepare the patient for a elective sigmoidectomy. You export the patient with the diagnosis of sigmoid volvulus.
Yes, sir.
What will you do on table? There is a twist. How will you release the volvulus? Untwist. In which direction you will move?
Sir, clockwise, sir.
Yes, because the twist occurs in an anti-clockwise fashion.
Anti-clockwise, yes.
So while you derotate, you should derotate clockwise fashion.
Clockwise direction, yes.
How will you decompress this huge segment of volvulus? Sometimes it is very difficult to handle this huge segment of volvulus. It may rupture.
Yes, sir, by milking of the gut.
Milking.
You see, most of this distension is because of gas. Once you could derotate, you can decompress parenally by passing a tube, or you can puncture the wall. Now you have derotated the sigmoid volvulus. What will you do?
Sir, I will check the viability of the gut.
If it is viable,
sir, I will do the resection and anastomosis, sir.
So
primary.
So the if it is a gangrenous resection, if it is not gangrenous resection, provided
hemodynamically stability.
Patient is hemodynamically stable and surgeon is experienced.
Yes.
Okay. So what are the ways you can manage this volvulus? One is resection and
sigmoidoscope, resection
and primary anastomosis.
Primary anastomosis, yes, sir.
Okay.
And sir, if the
patient is sick, patient is
conditions,
hypotensive, patient has hypovolemia, in that case,
sir, I will go for the sir Hartmann procedure.
Yes. What is Hartmann procedure?
Sir, we take out the. I will take out the proximal end of the bowel as a colostomy, and I will close the distal end and kept in the abdomen. And after 6 weeks or 4 to 6 weeks, I will do the anastomosis.
Okay. I think Dr. Bhattacharya, you have covered most of these things.
Yes. Now, I have only 1 or 2 questions. Now, suppose, yes, it was a closed loop obstruction, gangrenous gut, So you have to dissect the segment of the gut. Now, after dissection of the, say it is a mid-small bowel. So what will you do after dissection of the gut? Yes.
Sir,
So it was a gangrenous gut. You have dissected a segment of the small bowel. Then what should be your next procedure?
sir,
Small bowel. It was say mid-gut volvulus. So it was gangrenous. You have dissected a segment of the gut because it appeared to be gangrenous. So now there are two ends open. What will you do?
sir, primary anastomosis, sir, I believe.
If you do a primary anastomosis, what complications can take place later on or in the immediate post-operative period?
So maybe
After a
anastomotic
few
leak
days?
can happen.
Anastomotic. So to avoid the anastomotic leak, what would you suggest?
Sir, tension-free repair, sir.
Sure. So I'll be coming to the tension-free repair. Now, what other things can be done? Can you take out the open segment, proximal segment of the gut outside? And what will be the consideration about the distal segment?
Sir, mucus fistula.
Yes. So, and ileostomy can be done. Okay.
Yes, sir.
So, can you proceed for an ileostomy as well as mucus fistula in these situations? Going for the repair later on, say after about few weeks.
Yes, sir.
Okay. And the last question is, yes, you have done an anastomosis in a septic abdomen. Okay. You have washed it thoroughly and you have anastomosed. Now, can you tell me when you can really boast that your anastomosis is not going to leak?
Sir, sir, no idea, sir, but maybe after 7 days.
No. What are the preconditions or what are the conditions where you can really boast that your anastomosis is not going to leak?
Number one, you have done
albumin, sir,
with a good vascularity at the ends. Number one.
Yes, sir.
Good vascularity in both ends of the gut. Number one.
Yes.
You have done the anastomosis with sutures not under tension.
Yes, sir.
Okay. And now you also see that patient is having a hemodynamically stable status. Patient is not very severely anemic. Patient is having a good amount of serum protein.
Album.
I just a little point. So it is, I have said that you can boast. That means B-O-A-S-T. B stands for bleeding. Yes. From the ends, you can see that there is bleeding. Yes. Bleeding from the cut ends. O means there is no distal obstruction, no more distal obstruction. A means your approximation technique is really up to the mark. No problem, no technical problem. B-O-S. S means there is no prevailing sepsis in the abdomen. And T stands for tension is correct. No overtension. Okay. So in these situations, you can really boast that your anastomosis is not going to leak. Okay.
Okay. One more question. Dr. Bhattacharya number of times used the term closed loop obstruction. What do you mean by closed loop obstruction?
Sir, a segment of bowel is obstructed proximally and distally, which is mainly seen in the case of the volvulus or maybe in the hernial case where there is a tight ring around the neck.
Apart from this, tell me another example of a closed bowel obstruction which is not hernia or volvulus.
Sir, antegrade case of the...
No, not antegrade. You have an obstruction in the left colon.
Yes.
Can it cause closed bowel loop obstruction? And how?
The cecal volvulus?
No, not cecal volvulus. Volvulus is a closed loop obstruction. Yes, patient has got a left colonic stricture or growth causing obstruction, and ileocecal valve is competent. What is going to happen?
Consider that the cecum is
sir, there is a closed loop between, yes, sir.
Yes.
Sir. There is a closed loop between the ileocecal valve and, sir, the point of obstruction, sir.
Yes,
According-
yes.
Then the,
What is the peculiarity of closed loop obstruction? Suppose patient has got a volvulus in the small bowel and one segment of small bowel is obstructed. What will happen? Will this patient have a lot of abdominal distension? If not, why not?
sir, sir,
When
patient
there
will
is a
have,
closed obstruction, the
there's a lot of,
maximum distension occurs in this closed loop.
yes,
And
sir.
before the proximal dilatation starts, this closed loop may become gangrenous and get
Gangrenous and
perforated.
perforate. Yes, sir.
That's why in closed obstruction, the distension may not be very predominant. Okay.
Okay, sir.
Thank you, Dr. Anish.
Sir,
What I
thank you,
would
sir.
like to say is, in a quad round scenario, don't jump to examination or the management. Basically, you are trying to address the situation by taking a good history, doing a clinical examination, resuscitation, followed by the particular management. Okay. Madam,
Okay,
any
sir.
comment? Madam is there. Madam Banerjee, any comment or last question? Okay. Dr. Bhattacharya?
Okay.
Thank
Yes.
you very much.
Thank you. Thank you
Okay,
very
thank you, sir.
much.
Thank you. Thank you.
Thank you, sir.